Welcome to the CME Collective, episode 2. A couple of housekeeping items before we get into this episode. First of all, if you missed episode 1, you definitely should go check it out. It was a great first episode. We talked about vasopressin in shock and how that may or may not reduce blood transfusion. We also talked about epinephrine in out-of-hospital cardiac arrest, but we kind of went off on a bunch of tangents. We talked about mechanical versus manual CPR, what we should do about airway. And so I highly recommend checking out that episode if you haven't. Now, in this episode, we're going to actually change gears a little bit. We're going to talk about the use of backboards in trauma. We're going to talk about hard versus soft collars. And then hopefully we're going to close this out talking about a big trial that just got published called the CRASH 3 trial, looking at tranexamic acid for intracranial hemorrhage. Now, for those of you who don't know me, my name is SALIM REZAIE. Everybody just calls me Sal. I'm the creator and founder of a website called RebelEM. And we have an all-star cast today to kind of talk about these topics, and I'll let them each kind of go through and introduce themselves. Excited to be here.
Thank you so much, Sal, for the introduction. Hey guys, my name is SMETANA. I'm the co-founder and CEO here at IAMED. Been doing this for a while and definitely excited to be a part of the collective and seeing where the growth is going, and just being able to talk about good, new, exciting kind of, pertinent topics that I can use clinically in the field today. So, no, very happy to be here, Sal.
Great. Hey, everyone. I'm Mike HUDSON. I'm the medical director for IAMED. I'm also the medical director for Classic Air Medical and an ER doc in Flagstaff, Arizona. And, also super excited to be here, and looking forward to this great discussion.
And hey everybody, I'm Joey Lerner. I'm one of the hosts of the Echo Rotor Wash podcast. I'm a paramedic and a nurse, and stoked to be here too.
Yeah, that's a fun group of guys. So cheers, you guys. Let's have some fun.
Yeah.
Especially because we have some really good hot topics to talk about. Like I know that Mike, for instance, is super passionate about, soft collars versus hard. That's something that Classic started doing early on, and going back to the literature, you can kind of see that. But I guess starting out on the first one, like backboards, what are your initial thoughts on pre-hospital backboard? I just read the American trauma surgeon's recommendations, but I want to hear your guys' thoughts first.
Yeah, Sal, why don't you take off on that one, and maybe we can comment later.
Yeah, so I think, when taking a step back, when we look at these guidelines like ACLS, ATLS, I think a lot of these things are written for people who don't practice in these sorts of things like resuscitation or really sick trauma patients. So we have these guidelines to make sure that we all kind of follow the same protocol. But for those of us that are doing this every day, I think, we are up to date on what is best current practice. I think we know that when it's okay to go outside the guidelines. And so I think hard backboards is one of those things. It's in the guidelines. And my thought on hard backboards in trauma is that it's useful as an extrication device, but it serves no other purpose in terms of the trauma patient. And that's something that I commonly see in the ER is patients coming in with these hard backboards, and they've been on them for 30, 45, minutes to an hour. And the one thing they're complaining about is the pain in their back from being on that backboard. And so, that's kind of my initial thoughts, and would love to hear what others have to say about it.
Yeah, I think what you just said there speaks volumes about a lot of the topics that we're going to talk about in general, and that these, ACLS and all the other alphabet soup guidelines are kind of for the least common denominator. And once you become an expert, you're not bound by those guidelines. And certainly when the evidence makes sense, you should change your practice. And also, obviously I agree. I think that the hard backboard is great for an extrication device. It's great to be used for CPR, but outside of that, it's like waterboarding. It's a torture device.
Yeah, I love how you just equivalent that to be on under waterboarding, because that's kind of how it feels like. I've been a patient more times than I care to admit to. I've been flown a number of times too. I won't talk about how many, but I will tell you that every time, especially the first instance I remembered, I was down in Tucson riding my bike, and I got thrown almost 30 feet after sliding out, and I hit my head and I was unconscious, and I came to, and I had my wits about me, but at the same point, the first thing that I complained about wasn't the road rash or, the dislocated knee or anything. It was the pain of being on that board and the pressure it was putting on my hips. That's what I specifically remember. And to see,
Yeah.
go ahead. Go ahead, Joey.
Sorry to cut you off. I would say, yeah, if I've been a patient as well, and I have to say, I think the best way to ensure that you have back pain after a trauma is to be put on a longboard.
Yeah, it's not comfortable. It's not designed for comfort. It's mainly designed for a people mover, to get people from A to B. And I'm not going to lie, there definitely are times where I need that to move someone from A to B if I don't have a gurney with me, but then I just take them right off the backboard. I know growing up pre-hospitally, if you didn't come in with a backboard, like, you were chastised. On the air medical side, there's been a number of times where I have foregone the backboard or re-backboarding of someone because their spine has been cleared. But just because they're going from a tertiary care facility and they're labeled a trauma and they're going to a higher level of care, a level 1 trauma center, if I don't put them on a backboard and I go to a level 1 trauma center, I get my ass chewed. And it's kind of like a double-edged standard. It's like, well, their C-spine was cleared. We know that these backboards, even by the position paper on the American Trauma Association, they say, hey, the long backboards can induce pain, present agitation, respiratory compromise. So, it goes back to, why are we putting some of these patients on these backboards?
Well, I think the bigger question is, oh, sorry, Mike, go ahead and then I'll chime in.
Sure. No, I was just really quickly, I was going to say, frankly, I'm surprised that we still have to have this conversation. I mean, it's almost like the Selleck maneuver. Like, how many times do you have to prove that something doesn't work, before you can get rid of it? I mean, Denver got rid of them probably 10 years ago, and yet we're, and has shown no harm, and still we're using them. So yeah, frustrating.
The thought I was going to chime in with is, why do we immobilize people? And there's really two thoughts, if you think about it. The first is we're trying to immobilize the spine. And the reason we're trying to immobilize the spine is we're trying to prevent any further neurologic injury. And so does the evidence support those two questions? Does spinal immobilization actually achieve that or not? And I think there's good enough evidence to say, no, it doesn't actually.
Mm-hmm.
Yeah, I mean, I think there's actually good enough. Sorry, Mike.
That's okay. No, go ahead, Chris.
I also think I think there's good enough evidence to support that there's actually a negative. It actually is a detriment to patient care in some patient populations and in some situations. If you take someone with a pneumo, for example, a pneumothorax, and you go ahead and throw them on a backboard, well, one, you're already taking away their FRC. They've already lost a lung. You're trying to gain that back, and you're trying to do good mechanical ventilation. But by putting them flat and supine, like, I love Levitan's little saying, anybody that's supine is pretty much in the coffin position. That's the kind of way I look at it. It's like, hey, you're on your way out, buddy. Let me just help give you that push.
Yeah, absolutely. And I think to Sal's point, so I mean, and this argument carries over to the cervical collar discussion that we're going to have in just a bit. But I mean, number one, we're presuming that movement is going to worsen a spinal cord injury, and number two, we're presuming that a backboard is going to stop that movement, and both are false. So I mean, it takes a large amount of force to cause an injury. There's no evidence that movement causes secondary injury. The science just isn't there, and we can talk about that a little bit more with the C-collar discussion. And then furthermore, there's no evidence that spine boards preclude movement. In fact, there was just something, I just barely glanced through it, so I can't quote too much of it, but in a recent journal, there was a study looking at whether or not spine boards decrease movement, and essentially just because the friction coefficient of those hard plastic boards is so slippery, people move more on backboards. So you're actually causing harm. If movement were harm, you're causing that, which it's not.
And just to jump in real quick, guys, I think one of the things that I've seen the most of, the last few years, I've seen backboards phased out pretty well by most agencies. It seems like the one thing I still see a lot of, though, is those altered patients because they can't clear the spine. They're putting them on backboards. And again, back to what Chris said, you think about it, the worst possible position to put somebody who's altered in is supine. If they didn't have an airway issue before, they definitely do now.
Yeah. How many times have you guys, I can count on a number of my hands, how many patients I've literally had on a backboard that then vomited. And now I got to roll, decontaminate the airway, perform an RSI. And I'm not saying I could have avoided that by having them set, in a more of a 30-degree or head up position. I tend to say some of my patients probably could have at least avoided aspirating some of that stuff and going down that road of, of a decontaminated airway. The real question I want to ask the two medical directors that we have on the podcast today is from a medical perspective, me as a crew member, as a flight member, or as a ground ambulance, either way, if I have someone that is, within my protocols, like I just discussed, we go pick up a patient, they've already been cleared C-spine, and the accepting facility is so so steadfast in wanting to put that patient back on a backboard, you know, how do we as a crew member have a collective educated discussion with that accepting facility to advocate for our patients and not put them in re-backboard them? And there's cases where I've gone to bat, and I know Mike has had my back in not doing so, but you know, that's not the luxury that all these, you know, people out there that might not have. So for you guys, the medical directors, how do you guys think we could approach that clinically as a clinical provider in the pre-hospital environment for a physician that gives us crap and likes, you know, that likes to chat my ass just because I chose to be a patient advocate and go with evidence-based medicine, but now I'm wrong, you know? So you're teaching that clinician to go down a wrong, you know, down a wrong hole that we're trying to serve the other way. So.
Yeah. Sal, I think I can speak to that, just having dealt with this a bunch, if you don't mind. So I think that number one, you have to have a really good relationship with your medical director. Your medical director has to be your advocate. When those situations do arise, that's a doc-to-doc conversation. So that's when you call me and then I call the trauma surgeon and say, look, this guy either clinically or radiographically has a completely, you know, cleared spine. What's your reasoning for wanting to put them back on a backboard? And usually just nicely getting them to think about why not they may want to do something is enough. If they're, you know, just really steadfast about wanting to do that, it's sort of my prerogative, because the way medical direction works and the way sort of the chain of command works in EMS as far as what doc is in control of the patient is, number one, it's the sending doc, because he's the only one that's seen the patient. So he gets first choice as to what happens. Number two, it's me, because I'm in the air and I'm directing you guys. And then number three, last, is the receiving doctor, because they know the least. They don't know the HEMS unit's protocols. They don't know what the doc on the ground is seeing. And so ultimately, if the receiving trauma surgeon is just being a real jerk about it, I'm just going to tell them, no, we're not doing that. And then they can yell at me later and we can go over the evidence. So that's sort of the sequence that I would go through that.
What do you guys think about mattress devices as opposed to these hard backboards for these trauma patients? Like these mattresses that are almost like a hammock that kind of come apart in the middle. What are your thoughts on that for these trauma patients?
So are you talking about the scoop stretchers that kind of scissor together?
Yeah, exactly.
Well, it depends. I mean, there's the scoop stretchers that I've used before, like that scissor, and more likely you're going to pinch your hand and your fingers and cause a laceration on yourself than anything else, or the patient if you don't clear their back well enough. It does take a level of competency that I don't think agencies follow through with the scoop stretcher, especially if they don't use it on a pretty regular basis. What you end up finding out more is it looks like a bunch of monkeys at a circus, because they're all trying to figure out how to use this archaic device that they haven't used in forever. There have been mattress pads I've used with certain agencies where basically you stick it on there, you blow it up afterwards, and then from there, you know, it'll, sorry, I'm just gonna mute my other stuff. But from there, it does provide some padding where they don't move. They're a little bit more secured and it's a little bit more comfortable. But I haven't seen any studies that say, hey, mattress on a long spine board shows it, you know, an improved outcome, or, you know, no harm or detriment to functional residual capacity, airway management. And most importantly, if you have a neural injury, you don't want to have that patient supine. I mean, I talk about secondary brain injury. So I think that just looking at those different devices and what they're designed to do would be probably a better thing. But the scoop stretchers are, you know, I haven't used one in a while, thank goodness.
Yeah.
And just to,
you know, oh, go ahead, Joey, sorry.
Sorry about that. Just to jump in there too, Chris, I've used the full body vacuum splints quite a bit. And again, I mean, I think they're more comfortable if that's a measure, but you know, back to what I think Sal was saying is that there's still no evidence to show that immobilization is beneficial. And really they're not fully immobilized anyway. So yeah, you do give them some benefit of comfort, but it's not as comfortable as they would be if you just put them on the actual stretcher mattress.
Yep.
And
yeah.
Go ahead, Mike, go ahead.
Sorry. Two things. I think number one, the scoop stretcher basically is designed towards that fallacy that movement is going to create secondary injury, and so you're putting those halves together under the patient to reduce movement, and then they still end up on a hardish board. So for those reasons, I still think it's probably, you know, just like a hard board, if not more complicated and more expensive. And then speaking to Joey's point about the vacuum splint, just a quick pro tip for anybody out there on the ground: please put your patient on a sheet before you put them on the vacuum splint. While they're awesome in transport, they totally suck to get patients off of in the ER just because they have a ton of friction position. So if they're on a sheet, we can levitate them up off of that and pull the back U-splint underneath.
Yeah,
That's
the
definitely a
reason,
good clinical pearl.
yeah, it's a good pearl. The reason I was asking is because this is a problem when these people come to the ER. Forget spinal immobilization, forget worsened neurologic outcomes, but you know, studies have shown when these people come in, they've been on these boards for a long time, they have increased pain in their back. And we have all these clinical decision rules that help us kind of decide whether we should image somebody or not image somebody. How do you decipher somebody's pain is from the board or it's from the trauma that they just had? And I feel like we're doing more imaging, we're doing more CAT scans, it's more expensive, it's more radiation, like all the negative things you talk about with CAT scan that maybe we could avoid. And that's the reason I'm asking about the different types of boards. Is there one that might be more comfortable for the patients, or should we just go away from them altogether? I know what my vote is, but I'd like to hear what others have to say.
You know, I guess with my history in dealing with those backboards and just my clinical setting, I think I've had more clinical success by using the soft collar in the flight gurney, or, you know, the EMS stretcher and doing a slide over, you know, gently being mindful, obviously. But I think you don't aggravate more. You don't have this compounding pain. Like, is it really back pain, or is it just because they got back pain because they're on the stretcher? And so now we have to go image them, and we're giving them more pain meds that we might have not have given otherwise. So then that also lends down another path of, you know, you give an opioid, you take away the respiratory depression, CNS depression. So you look at those kind of things. My personal opinion would be, you know, that's just my personal opinion, is that, you know, I'm very comfortable with a hard, you know, sorry, not a hard collar, a soft collar in an EMS gurney. And it's just because I want to delineate, like, is this actual pain, or is this something that is secondary being caused by the device?
Yeah, I agree with Chris. I mean, I think all the evidence supports an EMS gurney and a soft collar and head blocks and tape. I mean, that's going to get you kind of the best of everything and eliminate the worst of everything. I think that's what the science would suggest.
Yeah, you can still sit them up at a head of bed, like, you know, 20, 30 degrees. You know, you can still protect their back. They're still in line if you position them appropriately on the gurney. And I think that comes back to just training education. You know, I've seen plenty of people inappropriately place people on the gurney, strap them in inappropriately. So if it's done appropriately, I think there's less, you know, cons than there are pros.
Just to hop in there, I think a really good clinical pearl for everybody, at least again, in my opinion, there are very, very few patients we should be transporting supine. Most of these patients should be head of bed up, 15 to 30 degrees minimum. I mean, obviously we know those intubated patients, but I mean, everybody else, even the conscious patients, they're going to breathe a lot better when they got gravity on their side. So I think that's something to keep in mind. I mean, in general, supine transport is really not something we should be practicing.
I mean, when you see patients in extremis, what's the position they want to be in? I've never seen a patient want to lay down flat because they're an extremis. They usually want to sit up. And I think trauma patients are no different when we're talking about that. I think that having them up 15 or 30 degrees it probably is a benefit to them. I've never seen a patient in extremis that wants to lay down flat.
Yeah, 100% agree. Whenever I teach any sort of a difficult airway course, you know, I always talk about, you know, if you were to go run around the block and then sit in this chair, would you lay flat like this? Or would you be, you know, lean forwards so that your, you know, your airway is optimally open and all the angles line up? So yeah, you're totally right.
And then even like we can talk about pulmonary function tests. I mean, you know, studies have shown that people's pulmonary function tests are worse when they lay down flat and supine on a backboard. And, you know, sitting up, you would get better because first of all, as population's getting more obese, they have just the physical weight of their pannus and their chest to like overcome. And two, they feel like they're drowning already, and laying them flat is not the position they optimally want to be in. And so we also improve pulmonary function tests, and many of these trauma patients will have rib fractures, or they'll have pulmonary contusions, or they'll have something else that's going on. And I think it's not in their best interest to lay them down flat and decrease their pulmonary function tests as well.
Think about their CVP. You know, if you have someone who's in hemorrhagic shock and you go lay them supine, you know, they're already, you know, third spacing, they're already bleeding out. They've already lost their SVR, their SVR is increasing. But if you think about their CVP, their cardiac output, I mean, you lay them flat, we take away 20% right there. And that's before the actual traumatic event. So, I think you look at airway, cardiac compromise, and all the other things. I'm with Joey. I think most of our patients need to be sitting up in an upright position, and that will help mitigate some of our problems. So.
Yeah, there's an interesting study, and I'm blanking on the name of the author right now, just because I'm in a hotel and don't have my notes in front of me. But they looked at this one was for cervical spine movement, but they looked at basically the amount of cervical spine movement if you were to roll up onto a scene, cut open a door, slide a backboard under the patient's butt, rotate them onto the backboard, and place a cervical collar, versus just standing up and putting a cervical collar on them and having them sit down. And it was drastically more movement when you did, the whole shebang and rotated them out onto a spine board. So I mean, we're not doing anybody any favors by putting them onto a spine board in any way, shape, or form.
Yeah, and Nadeem online on the Facebook Live is saying, he's been a BLS provider for years, and his backboard a long time ago was a Linus blanket, just an old-fashioned blanket. Looks like we're going back to those days, huh? Thank you for sharing, Nadeem, and Mike's following us too from Heavy Liza Helmet, man, brother. I am so sorry I don't have a patch back here, but guess what? You are here in spirit, brother.
So if I could hold everybody's feet to the fire,
yeah,
hard backboards in trauma patients. We're saying extrication device, but no other real use for them. I am in favor of that is the only use. Everybody else?
Yep,
Agree 100%.
Yeah, CPR board, but yeah, CPR board and extrication.
Yeah, patient movement. You got to move a patient. You got to keep them, get them in and out. Like that's a great device to get someone out of a car, get someone up the hill to my gurney for sure. But once they get up there, they come right off of it, and I don't use it as a secondary device. It's more of a facilitator, not a transporter.
Yeah.
All right,
hey, Chris. It looks like we got a message about KEDS. What do you guys think about KEDS?
Yeah, so that's a good question about KEDS. And I looked at the American College of Trauma Surgeons, that study they did, or maybe it wasn't that study. There was a study that I perused here before this meeting. It was talking about KEDS and how KEDS were shown to decrease respiratory compromise. I think my personal experience with the KEDS, it's once again a great device to facilitate movement. Get them in and out of a position of confined space or confined access. But then after that fact, it's once again, I open everything up and I let it go.
Are we allowed to cuss on this, Chris?
Let's keep it R, not all the way, but yeah, sure.
All right. Well, so my take on KED boards is if you really want to freak the F out of a kid, put them in a KED board. I mean, they've just been through probably the worst trauma of their life. They're scared, and now all of a sudden you wrap them up in this semi-stiff burrito, and it's ungood.
Well, and that's the other thing, like thinking from the patient's aspect. Joey mentioned he was a patient. I was a patient. I can tell you right now that I did not like being strapped to that board, and I'm comfortable. Like if anybody wants to know about claustrophobia, I'm very comfortable being claustrophobic. I've been through many tight confined space drills, and that doesn't usually freak me out. The backboard after post-injury definitely freaked me out. The inability for me to move my legs, to just do simple movement, because at the time I was unconscious, so they'd take my arms together. So, I mean, I literally, when I started coming to, I was stuck. I couldn't move. And what do you think I try to do as a patient? Even though I know clinically as a medical provider, I'm not supposed to be moving and thrashing, I was moving and thrashing. I basically told them to take me off the spine board, and I finally won. I was like, I'm not going to get transport. I'm going to refuse transport and go AMA. And they're like, what do we do now? I'm like, just take me off the backboard. I'll go in the ambulance. This thing hurts. So.
Yeah, for anybody who still has hard boards in their protocols, I advocate for them to go get strapped down, lay down on that sucker for an hour and see what you're doing to your patient. Now imagine your patient who might have a traumatic brain injury or have some other injury on that. But I promise you, because I've done this, I've laid for an hour, and after 20 minutes, my back was killing me. And I don't have any chronic back problems. So I advocate for people to go try and see why we should be taking these out of protocols.
Agreed. So, well, I think we all collectively agree that thing needs to be, and I like how one of the people on Facebook pointed out, they make good snowboards too. So maybe if you're in a pension Flagstaff doing a SAR or something like that, hey, great, I got a sled now.
Perfect.
I can confirm that.
Okay, awesome. I can neither confirm nor deny. No. All right, well, I guess moving on, soft collars versus hard, guys. Like Sal, actually, Mike, this is your field. This is what you're so passionate about.
Actually,
and you just recently published a study, right? So.
Yeah, so we, I guess for a little historical reference, about, gosh, probably 3 or 4 years ago now at my flight company Classic, because the evidence is so strong that they cause harm and don't do anything good, we took away all hard collars and have just been using soft collars only. We're about 2 years into a comparative study of that guideline change, basically just proving that that change didn't cause any harm. So that's not published yet. We're still collecting data. With the power to power such a study is pretty huge, and because it's just my agency and a ground agency, it's definitely taken some time to get there, but it's moving along fine. The insider view of the study is, so far I'm still a doctor and still have a medical license, so it's going good. We did just have one go to poster where basically just doing what Sal was talking about. I gave my lecture on soft collars. During the lecture, I had all of my providers wear a hard collar, and within 30 minutes, I mean, there were people that couldn't tolerate it. There were people that were ripping them off. There was several people had skin breakdown, and this is normal healthy volunteers sitting upright in a lecture that were getting skin breakdown. I mean, they're pretty nasty. So yeah, that's sort of my background on it. Sal, I can go on for this for days, so why don't I let you jump in before I take this over? I love your perspective on this.
Yeah, no, I can go in a lot of directions. I think the number one thing that jumps in my mind is a lot of the trauma patients that come in are intoxicated, and they don't have their wits about them. And we put them in these hard collars, and they're thrashing around because of this hard collar. And the simple move is just take the hard collar off, and they actually move less when you take that hard collar off. So I am all for anything that's more comfortable for patients who might have some form of traumatic brain injury or have substances that are on board. The other things are that if you look at airway, and I think most of us are taking the front of those hard collars off when we're trying to intubate people, but when you're not, the requirement for additional maneuvers or failure to intubate is actually significantly higher with those hard collars. And, people freak out about, oh my God, I'm going to move the neck if I take the front of that collar off. But I think most of us that are doing this are taking the fronts off. But I don't think there's a place for these hard collars either, much like the long spine boards. I think the soft collar is the way to go. Whatever is going to be the most comfortable for the patient, oftentimes is going to be the thing that's best for them.
Yeah, I mean, I think the way to frame the argument, I think it was in, gosh, like 2015, maybe ScanCrit put a great article called The Curse of the Cervical Collar.
Yep.
I may be misquoting that on the net. And they framed it basically in sort of a Mythbuster format, where they talked about, the number one myth is that movement causes secondary cord injury. The number two myth is that cervical collars prevent movement, and then the third myth is that cervical collars cause no harm. And then and I've since kind of use that as a framework to just look at this whole problem. And so the number one myth is that movement causes secondary cord injury, and it's just not true. That it takes the force in newtons of a draft horse pounding the side of your neck in order to create the initial injury. And so the thought that a little bit of extra movement like this is going to then create a secondary cord injury just really doesn't make much sense. When you look at the science of a secondary cord injury, it's not movement, it's swelling, inflammation, and hematoma that then compresses on the cord, and that's what causes the secondary injury. And then we can go into, and I'd love to hear your take, Sal, on how cervical collars don't really do anything to impede movement, and then you've already touched on the fact that they cause lots and lots of harm.
Yeah, I mean, I think the other thing is there are a couple of studies that done like MRIs looking at hard collar versus no hard collar. And I would argue that there's actually more distraction of the bony fragments with the collar on than there is without it on. And so you want to talk about making somebody move. Now you're stretching out a place that's injured, and now they're going to start moving more. And, there have been other studies looking at putting people in these collars and driving them around in ambulances, and they show that you still get up to about 2 centimeters of movement. So I think that this is, again, an antiquated practice, something we've always done. And so nobody's really looked at it to question why we still do this. And I agree with you, Mike. I see more harm from this than I see benefit. And let's not even mention patients with intracranial hemorrhage or increased intracranial pressure. there have been studies looking at putting these collars on them and then measuring that intracranial pressure, and it's increased with these collars because you're diminishing
Almost
venous
five.
flow out from the head.
Yeah, they should have increased in spike. I can't pull off the study right off the top of my head, but I remember the number, the figures was almost like 5 millimeters of mercury just by putting a collar on. Like that's it. Like, it wasn't that they had increased ICP, but they just measured it after the placement. And I think the other thing you look at, you know, in Jaron Jarrell on Facebook, you know, he pointed out rigid collars don't fare well with our altered trauma patients at all. We know that, you know, and if you think about it, they're altered. They're uncomfortable now because they're on a hard backboard. And then we put this rigid collar on them, which, let's be real, sometimes they don't get placed appropriately. So what's that patient trying to do the whole time? Trying to get comfortable. And as they're trying to get comfortable, they're going to be moving around and uncomfortable, and they're going to increase their ICP. You also look at the Crosby article that Sal shared earlier. You know, Crosby, you know, they came out with the summary of that saying basically, hey, only 2% of these are actually going to get displaced, even with a hard collar. You know, and those are probably going to get displaced anyways, regardless of what kind of device you put in. But if you look at the instance of how the increase in airway difficulty, the increase in airway compromise, increase of, you know, airway, just air movements and mechanics, that all is a huge detriment that I think takes away from that and negates that small 2%. 2% of displacement, okay, great. That's 2% out of how many thousands or hundreds of thousands of trauma patients every year. And now we're going to put them in a hard collar all because of that 2%. You know, that just goes back to that dogma of, hey, we've always done it this way, so let's just keep doing it, right? No, let's not.
Yeah, it's interesting. Oh, go ahead, Joey.
Sorry about that. Just to tap on, I reviewed a couple papers in the run up to this, and there's 2 lines from one paper that I thought were really interesting. The study wasn't super applicable. It was post cervical spine surgery. And then they also looked at healthy subjects with rigid and soft collars and the amount of movement they were allowed. But the 2 lines that I thought were really interesting to keep in mind is that both the rigid and soft collars allowed much more motion than was actually ever used during any of the 15 activities of daily living they had them perform while they were studying them. And then the second one is they said the collars don't restrict motion. They seem to regulate motion by giving the person greater proprioceptive input. And that only works if they're not altered. So that's saying that in alert, healthy people, a collar sort of works because they are more likely to notice the movement that they're making and self-align, but it means nothing in 90% of the patients we see.
Yeah. So that's, I think, you know, a lot of people ask me why I didn't just eliminate collars altogether and why I went to soft collars. And that's one of the reasons is sort of that proprioceptive feedback that the awake patient has. And the other thing is that it acts as a placeholder. So when a patient gets to me in the trauma center, and like ours have these big stickers that we actually stole from Min Lakong over across the pond. They've got, you know, big green stickers that say C-spine not cleared. And that way, anybody that's looking at that patient knows that even though they've got this foam collar that I call Judge Wapner collars that do nothing literally, it's a good placeholder to remind me to be careful and still clear their collar, or clear their spine, excuse me.
And just from a field level, I do believe that there is some utility in collars for intubated patients. I mean, just to be perfectly honest, there is something to be said for not having to worry about their tube and their head flopping around when they're, you know, sedated and paralyzed. But as long as we, you know, do that the best way possible.
Yeah, I think that's a good point, Joey. You know, I use them oftentimes in my pediatric transports, especially if they're intubated, just because it doesn't take much movement at all to displace that tube. You're talking less than 2 to 3 millimeters sometimes. In those patients, it's all goes back, and it's still a soft collar. It's all about being appropriately placed and then being secured. You know, if you secure your patient appropriately and you use the right device and you're trained and you know how to place that device, I think that's another big key. You know, we don't see those negative outcomes. We actually see better outcomes. We have better patient transports, and they're not as cumbersome. But I will say that, you know, trying to use a hard collar, you know, with someone who's misappropriately, misplaced it, and then you have to come in behind it, open it back up again, kind of align it, or if I have the opportunity to, I'm just gonna make sure it disappears and pull out my soft collar and say, hey, here you go. But we do have a policy in place where I fly, where if they're already in a hard collar, you know, we need to leave them in the hard collar or call medical control and just make sure that, you know, has C-spine been cleared, stuff like that. But no, there is a small place for them. It's just the rigid versus soft. You know, even in a pediatric patient, I would prefer a soft collar or towel roll, you know, around something a little bit different to kind of hold and stabilize those CT tubes.
And Mike alluded to this earlier, but skin breakdown is a huge problem with these hard collars, more so than the backboard. So take somebody who's not healthy, who's hypotensive, who's peripherally vasoconstricting and now not perfusing their skin. Now put basically what is the equivalent of a tourniquet, the length of their neck, and just you're begging for skin breakdown and pressure ulcers to happen. And it's more common in these hard cervical collars than it is even the hard backboard, because of how tight these devices go on. So that's just another thing, because in the day of, excuse me, in the day of reimbursement, and I'm not saying everything we do is about reimbursement, but if patient shows up with no pressure ulcer and then they develop one while they're in the hospital, you actually don't get reimbursed for that.
Yeah, that's a great argument. I never thought about that. That's a really great argument.
Yeah, and I didn't even like realize it until you had shared that pressure ulcer study, and I was like, wow, okay, well.